Okay, thank you, everyone. For folks on the call, we will now reconvene the meeting and continue where we left off. I see that we have a couple of ACIP members who have raised their hands. I apologize to our colleagues. If you'll just wait a moment, I promise I'll get to you. Dr. Sanchez is next.
Thanks, Grace. I just wanted to comment that the issue of equity certainly is very important, and the past comments about individuals of color. But when I look at slide 65 on the percent of people receiving COVID vaccine, it's across the board. I mean, even among whites, 36%, only 34% fully vaccinated. The message has to go out completely to everyone, because it's really, I mean, we're doing an abysmal job right now of vaccinating the American public. And I absolutely agree that the message has to be that the vaccine is safe and effective. Thank you.
Thank you, Dr. Sanchez. Dr. Sinayas?
Thank you, Dr. Lee. I also would like to address the issue of equity. My practice serves a largely underserved patient population, mostly Latinx, African American, and refugee patients who have been disproportionately affected by the pandemic. While there is some vaccine hesitancy in my patients, there's also trust in the providers in my practice. And the number one barrier that I hear is that the vaccine is too new or was developed too rapidly, and that it's quote unquote experimental. So I think that having full approval by the FDA and the ACIP would take away one of the barriers in my counseling. Thank you.
Thank you so much. Dr. Dooling, is there anything else you'd like to add, say?
No, thank you for those comments, and they do echo a lot of the discussion on the work group call. Thank you.
Thank you. Dr. Gluckman.
Thank you very much. One of the comments I wanted to make, I heard one of the ACIP members questioning the amount of data that we had that would be relevant to the Delta variant. And I recognize that we don't have the level of robustness that we heard presented earlier, but I believe that there's real world data that shows that the vast majority of patients in the hospital are unvaccinated. I did pull some data from our own health plan, and it appeared that 85% of the patients that are currently hospitalized are unvaccinated. I think it's important that we send a clear message that the vaccination is effective at preventing severe disease currently, unless there's any real disputes about the effectiveness of what we're seeing today. Thank you.
Thank you. Dr. Dooling, I see you pulled up a slide. Would you like to comment?
This was a slide presented in the presentation demonstrating just that point, that through the middle of July, incidence in unvaccinated people continues to be many-fold higher compared to those in compared to hospitalization in fully vaccinated people. I'd also like to reinforce that in the grade presentation, many of the observational studies were studied through July and some even in August. So many of the countries in which those studies were done, Delta was the circulating variant at that time. So there is information on the benefits of vaccination against Delta embedded within our grade presentation.
Thank you. Dr. Kim.
Oh, thank you, Dr. Lee. And I'd like to echo others in saying that was a terrific presentation, Dr. Dooling, as well as the other speakers earlier today. It's been a day chock full of information, and with really some very important discussions to take place still. I have a two-part comment / question. I wonder, Dr. Dooling, if we can go back to the policy question slide. So it was presented that as this slide shows, the relationship between FDA's EUA and the ACIP interim recommendation and the BLA by the FDA, and the fact that ACIP will be in a position to address a standard recommendation. Therefore, I ask that the committee to revise the policy question to should vaccination with the Pfizer COVID-19 vaccine be routinely recommended for people aged 16 years or older? There's obviously a big difference here. And that which leads me to the next question / comment. And I may be jumping the gun on this one, but I'd like to mention that if the vote today that will be taken is to be in favor of this policy question, I'd like to ask the committee members to discuss including the Pfizer COVID-19 vaccine in the adult immunization schedule and the child and adolescent immunization schedule. I realize that the interim changes to the annually revised immunization schedules has not been made in the past, and that was primarily due to keep the cycle of ACIP recommendations or ACIP recommendation updates predictable and to prevent possible multiple schedules to be in circulation. But given that we're in a time where many past norms are exactly that, the past, I believe that quickly incorporating routine COVID-19 vaccination recommendations in adult and child and adolescent immunization schedules are in order for ACIP to leverage these immunization schedules, their power to influence or command, if you will, clinicians' practices and behavior, and also to help boost vaccine confidence among providers and the public. So I'd like to ask the committee to consider that discussion. Thank you.
Thank you very much, and thank you for your comments about the critical nature of the vaccine schedule and the service that it provides to our provider community. I would like to say that should the ACIP vote in favor of this recommendation today, it will be adopted within the pediatric and adult schedule. We can definitely take those comments into consideration and how to represent it specifically for maximum clarity and benefit.
Thank you for the suggestions. Dr. Freihofer.
Thank you. Sandra Freihofer, American Medical Association. I want to just go back to the equity question again and sort of echo the comments of Dr. Brooks. I've had so many patients feel that this vaccine was just experimental because they didn't quite understand what emergency use was. The concept of EUA was sort of new to the American public. But now that this vaccine has been fully vetted, it has full FDA approval, I think that a thumbs up from ACIP will go a great way in instilling confidence. And we get that off the table. And now what we have to do is make it easy for our patients to get vaccinated and do the outreach and make it available and make it as easy as possible. That would involve, employers giving people time off and just making it more accessible.
Thank you.
Thank you. Dr. Mary Rubin, I think, wanted to just comment on the earlier question related to CICP. So I'll ask her to just make a brief comment, and then I think we will move on to the vote.
Thanks, Dr. Lee. I just wanted to reaffirm what Dr. Cohn said. So the COVID-19 vaccine is currently authorized through the FDA, EUA, or approved by the FDA are COVID countermeasures under the Public Readiness and Emergency Preparedness Act. And so individuals who think they might have an injury as a result of COVID-19 vaccines are eligible to apply for benefits under the CICP. Full FDA approval of the Pfizer COVID-19 vaccine does not remove its coverage from the CICP or provide coverage under the VICP. As a reminder, in order to add a new vaccine to the VICP, 3 things must occur. The vaccine must be recommended by the CDC for routine administration to children and or pregnant women. Congress must enact an excise tax on the vaccine, and that HHS must add the vaccine to the VICP through publication of a notice of coverage in the Federal Register. And that's not yet been done for COVID-19 vaccines to date. Thank you.
Thank you, Dr. Rubin, for that clarification. Dr. Sinayas, is your hand raised? Okay, thank you. And Just to state that this is not intended to stop the conversation in any way. I just would like to get a motion on the table. So I'm actually going to ask Dr. Dooling if she would be willing to put up the proposed language for the recommendation, having heard also some of the suggestions that were made. As that is getting put up, we will ask our voting members for a motion. And if seconded, we will pause and then actually open up for discussion once more. So the discussion is not done. Go ahead, Dr. Dooling.
Thank you, Dr. Lee. So just to walk ACIP members through the decision in front of them, the policy question is, should vaccination with Pfizer BioNTech COVID-19 vaccine be recommended for people aged 16 years and older? Next slide. Recall that the workgroup interpretation were that the balance of consequences, the desirable consequences clearly outweighing undesirable consequences in most settings, and support for a we recommend the intervention. Next slide. So the vote language is here. The Pfizer BioNTech COVID-19 vaccine is recommended for people 16 years of age and older under FDA's Biologic License Application, or BLA, approval. I'll turn it over to you, Dr. Lee.
Thank you. Sorry. So I see that I have some hands raised. I'm going to ask if a voting member wishes to make a motion. Dr. Paling?
Yes, this is Dr. Kathy Paling, and I would like to make a motion to accept the motion on the table. Thank you.
Thank you. So we now have a motion on the table. I'm going to look to the next hand to ask if you'd like to second the motion. Ms. Fata?
Yes, I would like to second. Thank you.
Thank you. So it's been moved and seconded that we adopt the recommendation language presented by Dr. Dooling as on the slide. And before we move to a vote, I'll invite our voting members to discuss the motion on the table. If there's any additional questions or issues the committee would like to raise before the formal vote. And I see Dr. Long's hand is raised.
Dr. Lee, can I interrupt for just 1 second and just clarify for everyone that this is in addition to, this recommendation would be in addition to the current recommendation that recommends use of this vaccine for people aged 12 years of age and older under FDA's EUA. And so to clarify, this does not take away the continued recommendation for use among 12 to 15-year-olds under the EUA for this product.
Thank you. And just to add to that, it also does not change the vote on the EUA for the third dose for the immunocompromised population. Great. Go ahead, Dr.
I wanted to say what Amanda just said about what the 12 and older still is on the table under EUA. And the other thing, Dr. Lee, you will know, or Amanda will know, Robert's rules, I believe, we are, the motion should be to approve, not to accept.
Yes, that's correct. Apologies for the misstatement.
Is there any further discussion, or would any of the members wish to make a statement or provide any additional comments? And especially if you've not had a chance to comment previously, we welcome any additional discussion. Dr. Cotton.
Hi, it's Camille Cotton. I would just like to say that I am very appreciative for the incredible amount of work that was presented today, and the really amazing amount of data that has been shown, and that it's wonderful that we are at this time where we can reach decision as far as whether we want to proceed with this recommendation. So thanks to everyone who worked so hard to get us to this point.
Dr. Lee, while waiting for anyone else to raise their hand, I just want to remind all of the ACIP members that for the vote, we will ask them to turn on your video cameras so that we can see the ACIP members, and also to restate their conflict of interest. I just wanted to make sure we got that in, and it doesn't look like there's any other hands raised.
Terrific. Well, we'll take the moment to actually ask our members to turn on their cameras in the meantime. And since I do not see any additional hands raised, I'll assume the committee is ready to vote on the motion. Thank you.
Great. Quick question. Will we be able to comment after the vote?
Absolutely. I'm happy to allow for comment after the vote. Thank you for asking, Dr. Talbot. Terrific. So we will proceed with the vote if there are no objections. All right, I'm going to go in reverse order today. ACIP members, please state your name, whether you have a conflict of interest, and then your vote on the recommendation that's listed on this particular slide. So we will start with Dr. Talbot.
Hi, Kip Talbot. No conflicts, and yes.
Thank you. Dr. Sanchez?
Sanchez, no conflict, yes.
Perfect. Dr. Paling?
Kathy Paling, no conflict, yes.
Thank you. Ms. McNally?
McNally, no conflict, yes.
Thank you. Dr. Long?
Sarah Long, no conflict, yes.
Thank you. Dr. Cotton?
Camille Cotton, no conflicts, yes.
Thank you. Dr. Daly?
Matt Daly, no conflicts, yes.
Thank you. Dr. Sineas?
Dr. Sineas, no conflict, yes.
Thank you. Dr. Chen?
Wilbur Chen, no conflicts, yes.
Thank you. Dr. Brooks?
Oliver Brooks, no conflicts, yes.
Thank you. Dr. Bell?
Beth Bell, no conflicts, yes.
Thank you. Ms. Bata?
Lynn Badra, no conflicts, yes.
Thank you. Dr. Alt?
Kevin Alt, no conflicts, yes.
Thank you. And Grace Lee, no conflicts, yes. And so with that, Dr. Cohn, I believe we have 14 yeses, 0 no's, and the ayes have it, and the recommendation is approved.
Yes, I concur. The motion passes. I think we're going to try to get the videos back up for people who wish to make comments. Give us one.
Thank you.
Give us 1 second, please. Okay, I think we at least have the video back up. I think we can go ahead and have people start commenting.
So,
yep.
Sure, that sounds good. Okay, I see Dr. Talbot's hands raised. Please go ahead, Dr. Talbot.
So I actually have a couple things to say. One is I would like to reiterate how hard our FDA and CDC colleagues have worked through this pandemic. They have been working extra hours, not just for a few months, but now for 18 months. And they have done this. I want to remind the American public that our public health infrastructure was stretched prior to the pandemic. And I would like everyone who made public comment in regards to how much more the CDC can do to remember to reach out to their representatives and congressmen and senators, that the CDC needs to be funded fully on a yearly basis with a stable budget to cover not only our routine health care so that kids are vaccinated for everything, but also to handle epidemics and pandemics. I think our colleagues have been very overworked, and I want people to know they are working just as tirelessly as they were in the beginning. But we need everyone else's help too to spread the news that this vaccine is safe. If you've been vaccinated, raise your arm and tell everyone about it and be loud and proud. I think the second thing I really want to bring home is our kids need to be in school, and everyone wants to do it with going back to completely normal. And I don't think that's possible. I think our kids are going to be scarred if we don't get them back in school. They need to be masks, and everyone who has anything to do with a child that's not old enough to be vaccinated yet should be vaccinated for the benefit of those children and for other loved ones who might be immunocompromised. So Once again, tell everyone you've been vaccinated, encourage everyone to be vaccinated. And I'm saying this not just as an infectious disease doctor, not just as an epidemiologist, not just as an ACIP voting member, but as a mom of 2 children. Please go get vaccinated so our kids can go to school. Thank you.
Thank you, Dr. Talbot. Dr. Chen?
Yeah, well, first of all, I want to echo what Dr. Kip Talbot just said, that I really appreciate what the CDC and FDA have been doing behind the scenes, and they're really unsung heroes continuing to work, for 18 months tirelessly. It's just been tremendous. Through today's presentations, which were really amazing, I've been highly encouraged by the clear demonstration of the safety and effectiveness of the Pfizer BioNTech vaccine that we saw. I also just wanted to emphasize that we don't have the expectation that the Pfizer vaccine or any of the other COVID vaccines confer immortality, nor invulnerability against predictable life events. For example, the occurrence of cancer, motor vehicle accidents, or other things that can cause someone to get hospitalized or die, and just because of timing, it's not related. I also wanted to just mention an imminent predictable event that is coming up, which is non-COVID respiratory viruses. As we return back to in-person classes for our children, as we enter into the fall and winter season, we should not be surprised by the eventuality of seeing a rise in infections from seasonal respiratory viruses like influenza, RSV, rhinovirus, and others, which we're already seeing right now as that signal. These COVID vaccines will not prevent runny nose, sore throat, fever, cough, nor the hospitalizations or possible deaths due to those non-COVID respiratory viruses. And, I have many pediatric medical colleagues that have voiced their concerns about the expectation of an overwhelming number of hospitalizations in children in the coming months. Medical systems are already preparing to surge upwards to 200 or more % of their normal capacities to handle these pediatric hospitalizations. And so, clearly the Pfizer vaccine and all of these other COVID vaccines have demonstrated a very strong track record for safety and effectiveness, especially in the prevention of hospitalization and deaths due to COVID. So again, this is just a warning for the upcoming season, because we're going to see other respiratory viruses mixed in with this present pandemic. So while we have an FDA-approved vaccine, COVID vaccine for adults, EUA authorization for children 12 years of age and older, in the coming months, I look forward to reviewing the data that we will have, hopefully soon, for safety and efficacy for younger children. And, certainly I'm looking toward having this vaccine be available to protect, this vulnerable and precious part of our population. I'll end my comment there. Thank you.
Thank you, Dr. Chen. I'm going to hand it over to Dr. Daly.
Yeah, thanks so much. So I have several broad comments I'd like to make. How will history judge this moment in time? This is a question that I was asked a few weeks ago during an interview, and I've been thinking about it ever since. And I think that there are several crucial developments that will be judged very favorably over the course of time. Last fall, several of our national health experts stated that we'd be fortunate to have a vaccine that was 70% effective against a new respiratory virus. And yet here we are with a vaccine demonstrating greater than 90% efficacy and 96% efficacy against death. And so, I think history is going to judge this as a moment of incredible scientific innovation. And then second, and this is my opinion alone, but I've been struck by how well our existing processes and systems have functioned in the environment of this unprecedented pandemic. And this will echo some of the comments that Dr. Talbot made, but I'd like to highlight the processes at work at the FDA. The Food and Drug Administration, they're responsible for protecting public health by ensuring the safety, efficacy, and security of drugs, biologics, and medical devices. And even with the urgency of the pandemic, the FDA has followed their established processes. maintaining an appropriately high bar for licensure. And some in the press and in the public have urged the FDA to speed up their reviews. And I would state in some ways the opposite. Take the time that you need to conduct the extraordinarily detailed and careful review that you'd perform with any other licensed medical product. And in fact, I'm confident that that's happened. And then I'd also like to highlight the work of this group. As Dr. Lee, our committee chair, has reminded us, the ACIP needs to follow all the established processes, including the rigorous grading of scientific data and the integration of this grade into the evidence to recommendations framework. And this process was just demonstrated so clearly by the presentations just given by Dr. Gargano and Dr. Dooling. And then finally, I'd want to highlight that prior to the pandemic, the United States had an extensive system for monitoring the safety of authorized and licensed vaccines. And this system includes multiple components, including the VAERS and VSD that we heard from today. And then during the pandemic, the system has been enhanced, such as by the creation of VSafe and by the addition of other federal partners that contribute data to this safety assessment. And then that system's allowed us to detect these rare but potentially serious adverse events following vaccination. And as Dr. Lee showed in her presentation, these data then are used to reevaluate risk versus benefit. And these data can also be used to mitigate adverse events whenever possible. So, I think we all fully recognize that the story's not all rosy, and there's many areas of concern. We've really suffered from a plague of disinformation and misinformation. And as many as 72 million individuals in the US 16 and older are not vaccinated. And we have these new variants that have emerged with increased transmissibility, and cases, hospitalizations, and deaths are on the rise. But even in consideration of these challenges, in response to that question I was asked about how history is going to judge this moment, my personal judgment is that this is a time of incredible scientific innovation, and I'm hugely grateful for that. And entering the pandemic in the United States, we were in the fortunate position of having established systems to license vaccines, to recommend vaccines, to evaluate vaccines using real-world safety data. And then these systems were enhanced for the pandemic, and they've really met the challenges of the pandemic and by and large have performed very well. And so I just think that the fact that we're here today voting on recommendations of a licensed vaccine against COVID-19 is historical in and of itself, and it just further reinforces the points that I've just made. Thank you very much.
Thank you for your comments. Dr. Peeling.
Hi, Dr. Kathy Paling. I wanted to also send my sincere thanks to the many people who've been working to make this day possible. I voted in favor after reviewing the large amount of safety and effectiveness data from randomized controlled trials, observational studies, and multiple safety monitoring systems. Over 209 million doses have been administered. The hospitalization rate among unvaccinated is much, much higher, over 19-fold times higher than that of the vaccinated. Delta variant is far more transmissible with high replication and viral loads, and is causing over 100,000 infections and over 1,000 deaths per week. Vaccines and masks work to protect us, our families, our children, and our community. I encourage all eligible to be vaccinated and use masks to protect you and all those that you love. Thank you.
Thank you. Would any other members like to make any additional comments? Oh, Dr. Long, go ahead.
Yes. It's really related to the schools opening, and it probably is not our purview. Before they will open, certainly before we have our next meeting, and at our next meetings, we will not have any vaccine in front of us to look at for younger children, at least for a few months. So I hope that we understand the tapestry of the epidemiology. I'm hearing about pediatric facilities with stuffed ICUs. Well, we have pretty good immunization in New York State, in Pennsylvania, in New Jersey, and I know in North Philadelphia, where we definitely have Delta virus, we do not have a surge of pediatric cases in the ICU. And I am concerned that for younger children, those that probably need this educational environment most, and especially in some of our vulnerable neighborhoods that are well immunized, that we might wonder if we can not impose a 10-day quarantine on a classroom or a child who might have relatively mild symptoms from coronavirus, et cetera. I just don't, this is not something we talk about a lot, although we have all become pretty good experts at coronavirus. So I wonder if Dr. Cohen or Dr. Wharton would want to say anything about the continuous scrutiny of the recommendations and your idea that one decision or one rule may not fit all communities in the United States.
Actually, this is Dr. Lee. I just want to keep us on task, I'll say, which is to say that, our purview today is on vaccines, and we still have a discussion ahead of us that I want to get to. I am going to ask us to skip our break. I did want to make one comment. Dr. Duchin, did you want to add something really quickly to this discussion?
Thank you, Dr. Lee. I just wanted to say that, this is a miraculous accomplishment to have such an effective vaccine so quickly. And I just want to remind people that right now, when not everyone can be vaccinated, and even when not all of those who are eligible are vaccinated, that we really need to use all tools at our disposal, in addition to vaccine, to fight this Delta outbreak in particular. And that means using the best quality mask, the best fitting and highest filtering mask you can, understanding the critical importance of improving indoor air quality through ventilation and filtration, and reducing high-risk activities. Vaccines are wonderful, they're miraculous, but we need to use all tools at our disposal right now. Thank you.
Thank you, Dr. Duchin. And I'll just add one last comment, and then we'll wrap up this session, which is I agree with the comments of many of my colleagues on the call about the importance of vaccination. The one thing I did want to emphasize is that the BLA is inclusive of pregnant women. And as we know, the ACOG, SMFM, and CDC have really strengthened the recommendations around vaccination of pregnant individuals because of the severity of disease that we're seeing. Just wanted to remind our colleagues and the public how important this particular population is, both because they're suffering far worse complications from COVID infection, with significant severity of disease, and it's also impacting their infants. I think this is an opportunity for us in that we know that only 10 to 15% of pregnant women are actually vaccinated. So we have a long ways to go. We've talked a lot about disparities. I actually think that, pregnant women, should be included in that mix, and we really need to think about how to strengthen our vaccination rates in the pregnant population. With that, I am actually going to suggest that we skip our break. I apologize to my colleagues, but we do have and we can turn off our cameras now. I'm going to suggest we turn off our cameras and that we move on to the, let me turn off my camera, sorry, to the next section where we will have Dr. Sarah Oliver present on a framework for COVID-19 booster doses in the U.S.
Thanks so much and good afternoon. Next slide. So to begin, I want to continue to distinguish what it is that we're addressing today. At the last ACIP meeting, ACIP recommended an additional COVID-19 vaccine dose after receipt of a primary series as a way to provide protection for those who may not have mounted an appropriate immune response to the initially recommended series. Booster doses are vaccine doses administered when the initial sufficient immune response to a primary series may have waned over time. This is what we will be addressing today. Next slide. As we think through the recommendations for booster doses of COVID vaccines, the main question we're answering is, are booster doses needed for those previously vaccinated with a primary series? As with other recommendations for COVID vaccines, we will review the data in a systematic and transparent fashion. Policy on booster doses will be coordinated with FDA for regulatory allowance and ACIP for recommendations around use. Next slide. As we discussed at the last meeting, recommendations for booster doses would obviously only apply to those who had completed a primary series. To date, over 365 million vaccine doses have been administered in the US. The figure to the left shows the number of people fully vaccinated by COVID vaccine series type, and on right shows the percent of the population fully vaccinated by age. Over 60% of those 12 years of age and over are fully vaccinated. Next slide. We also showed this figure at the last meeting, the daily count of newly fully vaccinated individuals. The average number of doses administered have been increasing since mid-July, and as a result, we're seeing increases in the number of fully vaccinated individuals. Next slide. Then this slide shows the newly vaccinated figure by age. If you look on the far right of the graph, the increases seen in recent weeks are primarily those 18 to 64 years of age. Next slide. So we also showed this slide last time as well, with our overall roadmap for the next several weeks to months. Next slide. At the last meeting, we discussed the framework for booster doses. Then at today's meeting, we'll begin to provide data to inform booster dose policy. Next slide. So then this is the framework that was presented at the last meeting, and we'll walk through it again today and fill in data where we can. Next slide. First, we'll review data regarding VE waning over time. Next slide. These are the Kaplan-Meier curves shown at the time of EUA review for each of the 3 authorized COVID-19 vaccines. At that time, the median follow-up was around 2 months. You saw data from Pfizer today regarding the longer follow-up for those in the clinical trials, and we'll continue to work with the manufacturers to review this follow-up from clinical trials at upcoming meetings. Next slide. Today, we will summarize recent US publications evaluating waning immunity listed here. You can see on the far right that the time assessed included data through July of 2021. Next slide. So this slide shows VE estimates against hospitalization from the studies listed on the previous slides. You can see VE estimates remain high over time. Next slide. This slide shows the VE estimates against infection from the studies listed. VE estimates have had some decreases over time for the last 1 to 2 months. There are a variety of reasons that we could be noting this decline. One aspect could be waning immunity due to time since primary series. However, there is another factor to consider as well. Next slide. As we've seen from previous presentations today around the increases of the Delta variant, in May, Delta was around 7% of sequenced isolates, and by mid-July, this was up to 94% of sequenced isolates. So the impact of the Delta variant leads us to our next question. Next slide. Is VE reduced for the Delta variant? Next slide. This figure shows VE estimates by outcome for the Alpha variant in blue compared to the Delta variant in orange. The outcomes range along the top, VE for any infection on the left, symptomatic infection in the middle, and hospitalization or severe disease on the right. You can see that among global studies assessing infection with Alpha versus Delta, there was a mild decrease in Delta VE. There may be a variety of factors that can impact these results and variation by countries, including differences in study methods, intervals between doses, and timing with vaccination and variant increases. Next slide. This slide shows results of studies that compare pre-Delta versus Delta estimates for VE. Infection or symptomatic disease is on the left, and hospitalization or severe disease is on the right. In studies comparing pre-Delta and Delta time periods, the pre-Delta VE estimates are high at 87% or higher. Since the introduction of the Delta variant, VE against infection ranges from 39 to 84%. VE against hospitalization, though, remains high from 75 to 95%. Next slide. So this is a summary of VE estimates since the introduction of the Delta variant. The colors correspond to the vaccines assessed in the study. This highlights that regardless of the vaccine evaluated, all vaccines remain effective in preventing hospitalization and severe disease. But there could be, maybe less effective in preventing infection or mild illness recently. These reasons for lower effectiveness likely include both waning over time and the Delta variant. Next slide. So we also need to evaluate how the need for booster doses may vary by subpopulation. First, we'll address adults 65 years of age and over. Next slide. This study highlights VE for symptomatic infection with the Pfizer vaccine for several of the recent variants of concern. Adults 60 years of age and over are in the light blue. VE against symptomatic infection in adults 60 and over is high, but some decreases are noted against variants of concern. However, it's important to note that these differences were not statistically significant, and there were small numbers and very wide confidence intervals for several of the different variants. Next slide. This slide highlights VE against hospitalization. VE in adults 65 years of age and over has decreased slightly over time, but has remained high. And again, differences by time interval since vaccination were not significantly different. Next slide. This slide shows unpublished COVID-19 data with preliminary VE against COVID-19 associated hospitalization among fully vaccinated patients 18 years of age and over by age group and month. VE remains high, 94% or higher for adults 18 to 49 in yellow, 50 to 64 in green, and 65 to 74 in blue. Preliminary VE against hospitalizations in adults 75 years of age and over in red decreased in July, but still remained over 80%. Next slide. So moving to VE among healthcare personnel, the figure on the left shows VE by days since the second dose of the primary series. And the figure on the right shows VE by variant predominance, the time period pre-Delta and the time period when the Delta variant was predominant. The VE against infection among frontline workers, including healthcare personnel, declined somewhat over time and from the pre-Delta period to the Delta period. However, again, the VEs were not significantly different. Next slide. This slide demonstrates VE against infection among long-term care facility residents. There was some question initially for how these older, potentially medically frail adults may respond to the vaccine. However, this shows that initially VE was high, 74% or higher by vaccine. Next slide. However, if we look over time, moving into the recent months where Delta was the primary variant, VE has fallen to just over 50%. Next slide. So this is the same summary slide as before, but to put the estimates for older adults, healthcare personnel, and long-term care facility residents into the overall context. Lower VE against infection was seen for long-term care facility residents. VE among older age groups and healthcare personnel are comparable with other subgroups, and follow-up is needed to monitor these VE estimates over time. Next slide. So next, moving to the other aspect of booster dose decisions, to review the benefits and harms. Are booster doses of COVID vaccines safe and immunogenic? Next slide. We know Pfizer, Moderna, and Janssen are all conducting studies to evaluate the safety and immunogenicity of booster doses. While we've heard about the immunogenicity of these booster doses reported in the press, it's important for us to review sufficient safety data for booster doses as well. At upcoming ACIP meetings, we'll have the manufacturers present data on third doses. Next slide. Next, will booster doses of COVID vaccines reduce COVID incidence, hospitalization, and mortality? Next slide. We're evaluating data available to discuss the potential impact of COVID booster doses in a variety of populations and settings. The data are limited currently. However, as data become available, we'll make sure to bring it to ACIP to inform these discussions. Next slide. Do booster doses improve VE against the Delta variant and then other variants of concern? Next slide. Immunogenicity data, including sera from study participants who received a booster dose, can evaluate neutralizing antibody data for variants of concern, including Delta. While there's no correlate of protection available, there is a growing understanding around the impact of neutralizing antibodies. This understanding can be used to infer the impact of booster doses from studies of neutralizing antibodies to clinical protection against Delta and other variants of concern. We'll have presentations to ACIP at upcoming meetings to address this as well. Next slide. And finally, we want to highlight that feasibility will be an important aspect for booster doses as well. Next slide. Some aspects of implementation will be more feasible than a primary series rollout. Supply and number of vaccination sites should not be a serious limitation. However, there will be some aspects of implementation that could be more complex. Individuals received a variety of primary series. Upcoming data will evaluate booster dose response for the same vaccine as primary series that we call homologous, as well as a different vaccine as the primary series, which we call heterologous. Booster dose policy will need to address individuals who received all primary series. Another aspect that could impact implementation includes the possibility of different doses. Some COVID vaccine booster studies have evaluated various doses for booster vaccines for the same product. The data on these studies will need to be reviewed and feasibility of implementation discussed. Next slide. So moving to the summary and workgroup considerations. Next slide. First, I want to highlight that it's not uncommon for a vaccine series to require several doses. Vaccines that require more than one dose do not necessarily mean that annual boosters are needed. For many vaccines, the final dose is given at least 6 months after the initial dose. This table shows a sample of vaccines that can be given to adolescents or adults that require more than one dose, and with the last dose given at 6 months or further. Next slide. This slide can attempt to explain why that occurs. This is clearly an oversimplification of vaccinology, but just want to highlight that the initial dose of a vaccine is typically thought of as a priming dose. It induces an immune response, which includes B cells, T cells, and antibodies. However, subsequent doses of the vaccine can produce a boost effect, which can lead to a broader response within the immune system. The time between doses can allow for more of the boosting effect within the immune system. In a pandemic setting, it can be important to achieve high protection early with a second dose given at a shorter interval. However, it may mean that a later dose for this boost effect is needed as well. And again, this doesn't necessarily mean that an annual booster dose would be needed. Next slide. The data we've seen today has demonstrated that COVID vaccines continue to maintain high protection against severe disease, hospitalization, and death. Protection against infection, including asymptomatic or mild infection, appears to be lower in recent months. It's very difficult to distinguish the role of time since primary series and the impact of the Delta variant on this. The data we've seen today were reported through July. Data through August will be shown at future ACIP meetings. It's important to monitor trends of effectiveness by severity of disease over time. Policy around booster doses requires continued evaluation of effectiveness, monitoring the impact of both time and variance, and the ability of booster doses to improve protection. Next slide. If we can recall back to December 2020 and early 2021, ACIP made recommendations for allocation of initial doses of COVID-19 vaccines in the phases listed here. Early in the vaccine rollout, ACIP voted for a risk-based approach to allocation of COVID vaccines, highlighting the highest risk individuals. However, we know that there was substantial variation in how this was implemented across states and jurisdictions. Next slide. So next, to move to workgroup considerations. The workgroup continues to emphasize that the top priority should be continued vaccination of unvaccinated individuals. Planning for delivery of booster doses to vaccinated individuals should not deter outreach for delivery of primary series to unvaccinated individuals. The workgroup also feels that the priority for booster dose policy should be the prevention of severe disease in at-risk population. And simplicity and flexibility will be important to support equitable and efficient delivery of booster doses. Next slide. It's also important to assure global vaccine availability. Uncontrolled spread globally that could result in new variants threaten control of the pandemic everywhere. In addition to global equity, policy around booster doses should consider equity in the US population as well. Access to booster doses may vary by population and setting. We should also apply lessons learned around equitable access in the early primary series rollout. Next slide. The workgroup highlighted that in addition to the immunogenicity data, we need to review available safety data for booster doses. The balance of benefits and risk for booster doses may vary by age and other factors. Any policy for booster doses needs to take this benefit-risk balance into account. And the workgroup emphasized that it's critical to wait for additional safety data and regulatory allowance for booster doses. Next slide. At this time, the workgroup has discussed a risk-based approach for booster dose recommendations. First, to prevent severe disease in the most at-risk population, primarily long-term care facility residents and older adults, and any age criteria can be discussed with further reviews of the data. And next, to support a strained healthcare infrastructure. We know that VE against severe disease remains high for healthcare personnel, but healthcare personnel with even mild disease may not be able to work, so prevention of mild disease takes on greater importance as a public health goal in this population. Time since vaccination with the primary series is also important. For many vaccines, a minimum interval is beneficial for boosting effect. However, the ability to benefit from this boosting effect extends well beyond that minimum interval. Next slide. So again, if we recall the initial allocation recommendations that were focused on the highest risk population and time since recommendation. Next slide. This slide again shows possible recommendations for the initial booster doses, with the populations mentioned on the last slide. Again, highlighting that this focuses on the highest risk individuals and time interval since receipt of the last dose. Next slide. ACIP will continue to review additional data. At upcoming ACIP meetings, we can review manufacturer data on safety and immunogenicity of booster doses, and also review effectiveness, breakthrough infections, and epi data through August. The workgroup and ACIP will continue to have further discussions around feasibility, implementation, and the balance of benefits and risk by age group and by population. Next slide. So to return to our outline, today we began to review the available data to inform booster dose policy. Next slide. ACIP can meet again mid-September to review data just mentioned. And then we can have a subsequent ACIP meeting after FDA authorization for any booster doses for a possible vote around populations for use. Next slide. I want to thank our fantastic team who's helped pull all of this together. Next slide. And so our questions for ACIP: does ACIP agree with the proposed risk-based approach for COVID booster dose recommendations that the work group discussed? And what other questions would be important for ACIP to address? Thanks. Thanks. And Dr. Lee, while people are thinking through that amazing presentation and thinking about their comments and questions, I do want to introduce Dr. Dimitri Daskalakis, who is part of our incident management for CDC and for the CDC COVID response. And we have some comments that we just want to make regarding how to use this COVID vaccine under the BLA and information that's important for providers. Dr. Daskalakis.
Thank you, Dr. Cohen. Excellent. Thank you, Dr. Cohen. So while you are thinking, I'll just introduce myself again. So I'm the Deputy Incident Manager over the Vaccine Task Force. And thank you for allowing me to come and just let you know what we have been telling our partners and jurisdictions around appropriate use of vaccine. So I'll preface by saying that these vaccines are a lot different than other vaccines and drugs that come to the market. So specifically, they are distributed by the US government and are under provider agreements that state very clearly that providers must administer the vaccines in accordance with all program requirements and recommendations of the CDC, the Advisory Committee on Immunization Practices, so you all, and the US Food and Drug Administration. Notably, this applies to both the EUA and FDA approved COVID vaccines. Accordingly, use of the products outside of those that have been approved and authorized by the FDA, so something that we would call with other drugs off-label, is not recommended. And it is important, again, to remember that this vaccine is much different than other vaccines coming to the market because it would also violate the provider agreement and could expose providers to the following risks. The first is administration of the product off-label or not following FDA ACIP guidance may not be covered under the PrEP Act or the PrEP Act declaration. Therefore, providers may not have immunity from claims. Secondly, individuals who receive an off-label dose may not be eligible for compensation under the Countermeasures Injury Compensation Program. And I did hear the question that came up earlier about this vaccine under BLA still being under the Countermeasures Injury Compensation Program. So if a patient experiences an adverse event, if used off-label or off recommendation, they may not be covered under this program. And also importantly, this is a condition of our agreements. So off-label doses would be in violation of the CDC program provider agreement, and that could potentially impact the ability of the provider to remain a provider in the CDC program. And lastly, administration fees may not be reimbursable by payers if the vaccine is used off-label or outside of FDA and ACIP guidance. Dr. Cohen, thank you.
Great. So in summary, this was just a reminder to people who are listening to this meeting today that while we are discussing the potential for using booster doses in the future, at this time we strongly advise against giving individuals an additional dose outside of the already recommended and authorized recommendations for immunocompromised persons. Dr. Lee, we can pass it back to you.
Thank you. That was a mouthful. Okay, so I'm going to actually turn it over to our ACIP members to respond to these questions that Dr. Oliver had put up, and I'm going to call on Dr. Alt first.
I agree with the proposed risk-based approach for the COVID-19 third dose recommendations. However, as you have already said a couple of times, Dr. Lee, when we talked about this, last November and December, we really didn't know that pregnant people were a group at our increased risk, and we have a dismal uptake of the vaccine. Also, when we talked last year, healthcare workers, few female and younger, making pregnancy more of an issue in that particular group. So if you ask me what other questions would be important for ACIP to address, I think that would be one of them. Over.
Thank you. Dr. Oliver, just jump in if you want to respond or add some context, but otherwise I will keep going. Ms. Bata.
Thank you, and thank you, Dr. Oliver. This really
Can we go back to the slide where the list groups are listed? Will you go back to...
Sorry, we hear background noise. Go ahead.
Apologies.
I want to bring back the issue of equity and kind of the lessons learned in this first round of focus of limited doses. And I know that that's not the case, that we probably have ample doses, but I think that we missed a really high risk group. And a lot of it was based on local decisions that were driven by ease rather than by equity. And if we're going to move in this direction, somehow I want to see the data. I want us to make sure that that data is out, that our partners, especially those that are responsible for distribution or for promoting vaccination, really understand who we are targeting. And I think that includes younger communities of people of color, our Latinx communities, our Black communities, our Indigenous people communities, where the rates of hospitalization and death are so much greater. And so again, equity, but we missed it to a large degree this first round, and I think we have to rethink it, and we need the data to understand it and communicate it more deeply. Thank you.
Oliver, I don't know if you want to respond.
Thank you. Taking notes.
Okay, thanks. I'll just keep going. Actually, if it's okay, I would actually like to sort of second Ms. Bata's comment about these risk groups. I do want to call out, and apologies for jumping in the queue, but I think we can relook at that list. The approach itself makes sense. I just want to make sure that there are certain populations that we focus on in this round. Number one, when we talk about an age-based recommendation, we talked about how that in and of itself introduced inequities. And then the second would be, I'll just highlight congregate living facilities, of which long-term care facilities are one population. I want to actually emphasize the incarcerated population, where we know that severe outbreaks have occurred, and that is an extremely vulnerable population. That is just one example of sort of a risk-based strategy that I just want to make sure we are robust in thinking about how we define that. And I do agree that as much data as we have available to support that decision would be extremely helpful. Next, I'll call on Dr. Paling.
Thank you. Actually, I want to, also agree with the approach and want to echo the comments of Ms. Bata and Dr. Lee about the importance of looking at race and ethnicity, because we know the hospitalizations and death rates are higher for this group. And so I do think we need to take some special time to look and come up with a strategy where we improve health equity and do so in a very clear way. We are in a very different situation now than we were in December, January, where there is enough vaccine. And so we will have a dual opportunity. One, I firmly agree with the importance of encouraging vaccine for all that are unvaccinated, but then also thinking about this third dose for those who could really benefit from it. Thank you.
Thank you, Dr. Paling. We'll move on to Dr. Sanchez.
Thanks, Grace. I agree with the, and first of all, I want to thank Sarah, Dr. Oliver, for really an excellent presentation, as always. And I agree with, with the risk-based approach. Certainly the long-term care facility patients and older adults and the healthcare personnel. I think that Ohio, which did an age-based approach, actually worked quite well. But I do have some questions about the whole issue of booster dosing. Is it an issue of waning immunity after the second dose or first dose of the Janssen product, especially since we don't have a good correlate of antibody protection? So is that an issue, or is it because of the Delta variant as we've seen? And do we need a modification of the current vaccine to further improve the efficacy, especially against infection? And the other comment was, how has the opening up of society with less stringent with less stringent measures to beyond vaccination, how has that affected the increase of transmission that we're seeing with the Delta variant, and how does that go into effect? How to take that into account in the recent what appears to be the lower vaccine efficacy over time? Thanks.
Dr. Lee, this is Dr. Oliver. I'm happy to just highlight, Dr. Sanchez brings up a couple of good points, and I think our data tried to highlight that it actually may be very difficult for us to disentangle time since vaccination and the impact of the Delta variant, especially in some populations that we know were vaccinated earlier in the time course. So if we see waning in the last couple of months, it could be really difficult. We'll continue to bring as much data to ACIP as we can, but agree that those are very linked potentially, and so that'll need to be addressed and thought out as you guys think through these booster dose recommendations moving forward.
Thank you. Dr. Abel?
Thank you very much. And first of all, thanks to the team for a really wonderful presentation, the clarity of which I think is just so helpful in terms of moving forward. And there are a few things that I wanted to comment on. The first is, I think one of the other things that the presentation shows is that process really does matter. And I think it's quite important that we're continuing to highlight what our process is and how we get to a point of making recommendations. The second thing I wanted to say is that I think that it's really quite encouraging to see the amount of data that that has been accumulated over a certain period of time, but also to highlight a lot of the gaps in our knowledge, like we were just talking about, and like Dr. Sanchez was just talking about, and also some of the issues about safety. And so I think that it's also important for us to continue to recognize what the data gaps are. And in that regard, I think the third point that I wanted to make is that I think when we discuss this issue of boosters, we have to remember that we're starting at a point that the data to date doesn't show a remarkable reduction in the effectiveness of the vaccines in terms of preventing hospitalizations and deaths. And so when we talk about equity, when we talk about what our approach is to, whether we should have a risk-based approach or how we should do this approach boosters, I really think we need to remember that really the most important thing that we can do with respect to vaccines is to continue to work as hard as we possibly can
to encourage more people to get the primary series. And that is, I think, in my opinion, the highest priority. And so in that context, I think that while I agree that should we decide that it makes sense to recommend booster doses, that it does make sense to do that in the context of looking at risk. But there's a number of fairly fundamental differences between the rationale or the need for the risk-based approach when we first took this whole issue of vaccination recommendations on and the current situation. One being, as people have said, we've got lots of vaccine, and two being, as I was just pointing out, at the moment, we don't have a lot of evidence of reduced vaccine effectiveness against important outcomes in most of the population based on our current data. So while I agree that it makes sense to look at subpopulations as we consider boosters, I think that, how this all plays out and what the sequencing might be and what the timing of the sequencing might be quite different than the way we did things when we were talking about the primary series.
Thank you. Are there any other ACIP members who wish to make a comment or ask a question? Before we move on, Dr. Brooks, go ahead.
I had to unmute. So just briefly, as we look toward this risk-based approach, there might be the need to have some level of simplicity versus complexity. And by definition, this lends itself toward complexity. But if it's too complex, that might be put a challenge in the implementation. So as we move forward with this, we need to, I believe, think about that aspect of it to make it just not too difficult to follow and or to implement.
Thank you, Dr. Brooks. Dr. Talbot?
Yes, I want to go back to the comments made by the FDA, and I think these are critical. Since the announcement was made that vaccine boosters, which I agree with Dr. Watkin, that's not a good word, third doses would be given starting September 20th. And since the South is having a horrible outbreak of Delta, many hospitals have already started vaccinating healthcare workers with third doses and patients. Now, I know the announcement followed by the White House had that small caveat in that it has to be approved by the FDA and ACIP, but I think since it was given with a date, many assumed that it was given a blessing by the White House, and this was the next step. And so it makes me a little concerned that these healthcare providers will now not be covered by the PrEP Act, because many people didn't read the fine print. So I think this highlights critically the need for any vaccine recommendations to go through the normal avenues and not come out from outside of the normal avenues. That is very frightening to me that healthcare providers are trying to do the best job that they can, are taking guidance from HHS and White House, and now have put themselves at risk. Thank you.
Thanks, Dr. Lee. I just want to clarify, just so everyone knows, the Dr. Doskalis, who just spoke, was from CDC, not FDA. I just want to clarify that one comment.
Thank you. Dr. Brooks, I see your hand is still raised. I'm assuming it's left from before. I know we're nearing the end. I actually will get to all of the people who raised their hands. I just, as an ACIP member, wanted to chime in on two key points in terms of my thinking about the approach. So I was struck by the fact that some people try and make it an either-or situation. I would say that the strategy in my mind is much broader, and the strategy right now for where we are in the pandemic, to me, it makes sense to focus on preventing severe disease, hospitalization, and death, which is why, in my mind, a strategy that highlights the importance of vaccinating the unvaccinated, who are the ones predominantly getting hospitalized right now, as well as ensuring that those individuals who may continue to be vulnerable to hospitalization and death, particularly older adults, are included in the conversations about boosters. The other alternative would be a strategy that focuses on preventing all infection. I guess my concern is that we are not at the point in the vaccination program in the US or globally where that seems to me to be achievable. And so I feel that it would be important for us to focus our efforts on preventing severe disease because variants are going to continue to emerge over time and will evade our ability to prevent all infections. As one of my colleagues has said before, it doesn't mean it's a failure of vaccines in any way. In many ways, I think this vaccine is a huge success because it has prevented so many hospitalizations and deaths. So I just don't want us to lose focus on that as a key strategy that we need to address until the global situation actually improves and until we can get to a point where I hope it would be possible for us to even consider eradicating infection. I'm just not convinced we're there yet until we can ensure that those individuals who are not yet vaccinated are able to receive vaccine. So hence, that's my sort of thinking about the strategy that we've employed. The second, I just wanted to comment on the equity, the issues that are raised by the legal considerations from the PrEP Act. I want to acknowledge the importance of and appreciate the clarity in which it was presented to us today. I don't think I had that clarity before. I do want to raise as a clinician that it does raise some equity issues in my mind in that if we have a complicated program in that there are a number of vaccines all in different stages of the process of approval. And that means that this could introduce significant equity issues by vaccine product if we are not able to address this from what makes, to me, to be common sense, that it should not be a product-specific approach to boosters, but rather a global approach to boosters with available vaccine products. I say that not, recognizing that that does not is not concordant with what was just stated. But as a clinician, it puts us in an impossible decision if we have to go product by product in this case, if we're trying to communicate with the public about the importance of protection against severe disease. And so I guess I would just ask that our federal colleagues take that into consideration in interpreting the information around the PrEP Act and enable us to have flexibility to ensure the intent of any guidance or recommendations coming from these groups can be applied appropriately and not based on a specific product. With that, I'm actually now going to, I don't believe there's any other hands from ACIP members. So I'm going to turn it over now to our liaisons. Dr. Goldman, thank you for waiting patiently.
No, thank you so much. And I'll be as brief as possible. First, Dr. Oliver, as always, amazing presentation. Great concerns on the practice level regarding boosters and what is currently going on in many localities where people are getting vaccinated for a third dose on their own without any recommendations, non-immunocompromised, and many localities and vaccinators are just giving out vaccines to whoever asks. My concern and my ask for the CDC is clear statements and guidelines that we can discuss with our patients as to why it's not a good idea for them to just go ahead and get themselves vaccinated without good recommendation or guidance from the CDC in the non-immunocompromised. And this also applies to many of my colleagues in the healthcare world who are going out and getting themselves a third dose as well. And we already referenced the PrEP Act. But there's also, as previously noted, the great concern on equity, as many patients who don't have the means to do so are not able to get their primary series, let alone a third dose. So the concern is over-vaccination of patients who are doing it without guidance. I would ask for a clear statement from the CDC so that we can properly counsel our patients as to why they should be waiting for the guidance from the FDA and the CDC for full approval on a booster dose. And as far as the questions asked, I think the risk-based strategy is the right approach, and I look forward to further discussion on this on the work group. Over.
Thank you. Dr. Dries?
Thank you. I also wanted to thank Dr. Oliver for a really great presentation and for clearly outlining all the various issues. I just wanted to restate two things. One is the importance of protecting the healthcare workforce. As everyone is aware, it's not shortage of PPE or shortage of testing supplies or all the other shortages that happened early in the pandemic that is putting this strain on our healthcare system now, but shortage of staff. The second thing is, Dr. Oliver really clearly stated the data that we have, the data that we don't yet have but hope to have, and probably there are data that we won't have when we make this decision about a third dose for healthcare. Many institutions have moved toward making COVID vaccination a condition of employment based on the strong ACIP recommendation. And presumably, if a booster is also recommended, that would fall under that as well. And I think for many institutions, that's been a pretty dramatic move. And it's really been justified by the fact that we were following the data. So I think we just need to really be conscious of following the data for the booster dose as well, because just as there are many healthcare workers who were our early adopters already clamoring for their third dose, we are still trying to get first doses into healthcare workers who remain reluctant. And if we then say they have to also get a third dose that's not fully evidence-based, that potentially can make them even more reluctant. Thank you.
Thank you. Ms. Arthur?
Thank you. Phyllis Arthur with Bio. As we move into the fall with the potential for a booster dose and flu vaccine, et cetera, it would be great if the working group can consider how to help clinicians think through co-administration so that we don't fall behind on flu and other routine immunizations. And secondly, I think one of the things that everyone's struggling with when you read the media is this conversation of third dose versus booster dose. And I would really strongly encourage us to try to be really clear, as Dr. Oliver was in her presentation, about what the difference is between a third dose and a booster, because they're getting interchanged in the media and in public discussions, and I think are causing a lot of confusion about who should get what. And I know it's hard for us to stay consistent, but I think we're going to have to try to really be vigilant on those two words because, again, they're causing confusion from people for what they're supposed to be getting next. Thank you.
Thank you. Ms. Stinchfield?
Yes, thanks, Dr. Lee, and thank you, Dr. Oliver, for a great presentation as always, and so many wonderful comments recently here. I'm going to just narrow mine down to my last one that hasn't been mentioned yet, which is on the global vaccine availability slide. Wondering, Dr. Oliver, if you could bring us some data on a regular basis of the United States contributions of vaccine to other parts of the world, knowing that if there's COVID anywhere, there's potentially COVID everywhere. So I do think that should be part of our ACIP deliberation is not only just American first doses, but globally. Thanks.
Thank you. Ms. Howell?
Hi, Molly Howell, representing the Association of Immunization Managers, the 64 awardees responsible for distributing and implementing COVID vaccination. I just wanted to echo comments made previously. We would appreciate if recommendations could be as simplistic as possible. Providers have been dealing with changing expiration dates, changing storage and handling. So as much as possible, if there could be a very specific minimum interval and interchangeability between vaccines, it would be appreciated, I'm sure on behalf of our providers, but then also thinking about immunization information systems and having to create forecasts for booster doses. I also wanted to echo comments around thinking about equity. In North Dakota, American Indians represent a large percent of our population, and their life expectancy is not as great as the white population in North Dakota, and they often don't put their elders in long-term care, but live more in multi-generational households. So if any of that could also be taken into consideration, that would be appreciated. Thanks.
Thank you. Dr. Freihofer.
Sandra Freihofer, representing the American Medical Association, but speaking as a practicing physician. Dr. Lee mentioned using common sense when giving boosters and making recommendations. And understand that when we open a vial of this vaccine, you have to use it that day. It has a limited shelf life. The previous speakers spoke about the expiration dates that vary. I'm a general internist, and I have a lot of patients that are older, that have multiple chronic conditions, that are high risk of infections, and we're among the first group that was vaccinated. They're not on chemotherapy. They have not had a bone marrow transplant, but I'm sort of that many physicians are in the position that they have a vial of vaccine. They can either, they're going to have to throw doses away. And every time a vaccine dose is thrown away, I think about someone in the world who needs it. And it just breaks my heart. I think some of the comments that were made today are a bit confusing. They're going back to the sticks rather than the carrots to get people vaccinated. It's also sending a mixed message when we're trying, on the one hand, ACIP gave the thumbs up today. FDA has fully approved this vaccine, and we're saying, oh, come get vaccinated. And then we're pushing people back. When the White House or HHS made that September 20th availability, it led everyone, it led physicians, it led the public to believe that they had access to information about these vaccines and the need for boosters that had not yet been publicly released. And to me, that kind of opened the door to a lot of confusion. And then when we hear today about, this threatening providers with the PrEP Act and all that, it's not, we need to all go in the same direction to get everyone vaccinated, to get everyone protected, and to keep everyone protected, and not to waste this precious resource.
Thank you. Dr. Duchin.
Thank you, Jeff Duchin, Infectious Disease Society of America. In follow-up, I think it might be useful to consider resetting our expectations for what these vaccines can do. They're remarkably effective vaccines, and they're providing tremendous benefit in keeping people out of the hospital and from dying. And it's an inactivated vaccine, and whether it's reasonable to expect that they'll prevent all infections or even the majority of infections, I think is questionable. And so, going forward, we need to think, what are we trying to accomplish with these vaccines? And I think there's a tension here between waiting to see evidence of increasing serious outcomes to make a recommendation for a third dose. And I do think Dr. Plotkin's framing of this as perhaps more appropriately a 3-dose primary series with more durable protection than a so-called booster is very good. But I'm thinking about whether or not we can model, based on what we know about antibody kinetics and the outcomes that we are seeing, whether or not we would expect to see more serious outcomes before that actually occurs, and allow ACIP to make a proactive, preemptive recommendation rather than waiting for the evidence of severe outcomes to make a recommendation for a third dose. Thank you.
Thank you. Dr. Gluckman?
Yes. Do we know if Pfizer or Moderna and a third dose booster will have modified the mRNA vaccine for greater effectiveness for the Delta variant or other variants of concern?
This is Dr. Oliver. We will be bringing data around that for upcoming meetings, both primarily looking at immunogenicity and neutralizing antibodies by variants of concern. But we'll be asking the manufacturers to present at upcoming meetings.
Thank you.
Thank you. And I do not see any additional hands raised in this moment. So I'm going to thank Dr. Oliver for reflecting the breadth and the depth of this complex set of conversations the work group has been having, and want to thank everyone today for your participation. It's been so important. I also just want to emphasize that, it's clear that all of us who are, at this meeting today and all of our colleagues at the federal agencies and the White House are committed to ensuring that we're able to protect the health of the public. And we all have the same goal in mind. I think what we hear today is, the fact that with uncertainty in data, there are many paths forward. And so our goal is to try and find a way to make sure we have a deep understanding as much as possible of all of the issues and provide our best possible recommendation to the public. And we'll do our best knowing that data are uncertain and again, that everybody has the best intent in mind. So with that, if there are no further, no objections or to adjourning today's meeting, which I do not see, I will now be very delighted to adjourn today's ACIP meeting and thank everyone for attending. Dr. Cohen, is there anything else?
No, just thank you, and thank you for those final comments. I think that is very reflective of how all of us feel. And finally, just please be on the lookout for upcoming additional ACIP meetings to present additional data and to deliberate potential use of booster doses. As you've all said, the data are emerging every day, and we will pull things together and bring you all back to get your input soon. So just to the public, we will announce meetings as soon as we have dates. Thanks.
Thank you. The meeting's adjourned. Have a nice day. Bye.